happy to be here. We thank you guys for letting us come and present today. Our presentation is over oral hygiene. We'll be talking about proper oral hygiene, how to take care of the patients that y'all see here. We'll be talking about systemic conditions and how those affect the oral cavity. And then we will show some different slides, and we'll just run through our presentation real quick.
Introduce yourself. So I'm Emily.
I'm Tina.
I'm Mariam.
And my name is Summer.
And we are in dental hygiene program at Columbus Technical College. We are in our senior year right now.
So the topics we're going to go over is gum disease and stages and progression of gum disease, systemic conditions that are linked to gum disease, the proper oral hygiene methods, care of dentures and various prostheses, and how to look for like lesions and oral cancer within the mouth of your patients.
So why this information is important? Because it provides effective preventive interventions, reduction of disparities in preventive and dental treatment, and it improves the quality. Don't use the mic. And this oral hygiene information will also improve the quality of life.
This on.
Testing, 1, 2.
Perfect, thank you.
And it also improves the quality of life.
Okay, so the first thing that we're going to go over is the stages of periodontal disease. So on our first photo on the left, you have healthy tissue. You have no bleeding or puffiness. Pockets are measured normal with our probe. Our probe is an instrument that we use to measure the depth in between the gums and the tooth. It can go up to 12 millimeters. So for healthy tissue, the probe depth measures are 3 millimeters or less. And then you have stage 1 of periodontal disease. You can see that on the bottom of the radiographs that the bone is going slightly down. You're seeing bleeding gums, puffiness, they're very red. There's no damage to the supporting bone at this stage. Stage 2, you have bleeding and puffing gums that measure slightly above normal, 5 millimeters. You see more of the bone receding. And then you get to stage 3, which is moderate periodontitis. You have bleeding swollen gums with pockets that are 6 millimeters and above. You start to see recession of the gingiva, and you'll see the bone receding more. You have advanced periodontitis, where you are seeing more of the crown. You're starting to see the root because the bone has eroded away significantly, and that is periodontitis.
All right, so we're going to talk about the first stage of gum disease, and it's gingivitis. It is caused by the plaque and bacterial accumulation underneath the gum line. It causes the tissue, the gum tissue, to change in color and consistency and the texture. Some symptoms: the gums do become enlarged and inflamed. They'll become red. They'll turn colors like reddish purple or bluish purple. And it does bleed easily. It is painful, and there is no bone loss with this stage, at the first stage. It can be reversible if proper treatment and proper oral hygiene is implicated, but if it is left untreated, it will progress to the next stage, which is periodontal disease, and then you'll start seeing destruction of the bone.
So this is periodontitis, and this gum disease is irreversible. And the reason why this is irreversible is because you're losing your bone. And this gum disease damages the gingiva and the bone surrounding the tooth. Your gums can appear purple, red. They're very sensitive. This can be painless.
And you'll also see like loosening of teeth, and your teeth are going to start shifting and moving. You're going to start seeing your gums start receding, and you're going to see more of your tooth showing. And then you can also have frequent bad breath. And this is the gingivitis can progress on to periodontitis, and we want to stop it at gingivitis.
So the next is systemic implication. The relationship between periodontitis, which is gum disease, and systemic condition is a two-way street. Periodontitis has been associated with a number of systemic disease, including diabetes, cardiovascular, respiratory, dementia, and medication side effects. So think about it this way: our oral health is so much more than just the health of our mouth. If our gums are inflamed, the bacteria will get into the blood and it will travel throughout the body and will cause inflammation and infection throughout the body. So that's why oral health is so important. Keeping the mouth healthy for the residents. They are aged. They have more exposures to different kinds of things throughout their life, So that's why.
So diabetes. People with uncontrolled diabetes are 2 times more likely to develop periodontitis than an individual who does not have diabetes. This is because the excess amount of glucose within the saliva feeds the bacteria within the mouth. It contributes to periodontitis. So uncontrolled diabetes leads to hyperinflammation response to the bacteria and impairs the resolution of inflammation and repair. It contributes to the progression of periodontal disease and delays the healing after treatment of periodontitis.
So just a little bit more about diabetes. There are some oral manifestations, and they include reduced salivary flow. And when you have a reduction in the saliva or the saliva flow within the oral cavity, you're more prone to dental caries or decay. You're also more susceptible to fungal infection and the progression of Candida albicans. You will also experience burning mouth syndrome. It kind of feels like your mouth is constantly on fire or burning. You will see some periodontal abscesses, which are very painful, and that is just due to the infection that is underneath and around the root of the tooth, and it can cause a destruction in the bone. You have enlarged salivary glands, which can be kind of painful too, and then chelosis and also periodontal disease.
Okay, and I'm going to go over how to help patients with diabetes with their oral care. So it's really important to have a meticulous daily oral care. You want to make sure your patients are on a frequent recall for dental visits and dental checkups. The daily use of fluoridated products like fluoridated toothpaste or mouth rinse, and saliva substitute like Biotine, especially with patients who have really dry mouth. And these are just some of the things that that can appear in the oral cavity for a patient who has diabetes. Salivary dysfunction, they have like their tongue's really dry. Halitosis, they have bad breath. Gingivitis and periodontitis, like we went over earlier, they can have abnormal taste in their tongues. Oral infection, dental caries like dental cavities, and like the planus, like we will go over in a little bit.
So now I'm going over cardiovascular and how periodontitis, gum disease affect our heart. So periodontal disease and heart disease share some common risk factors. The bacteria as mutants, which can cause dental caries. It is the same bacteria that cause infective endocarditis. Also, the patient with periodontal disease are 25% more likely to get coronary heart disease. It is the most common heart disease, and it accounts for 42% death in cardiovascular disease. So when gum disease causing bacteria can get into the bloodstream and cause inflammation within the heart wall, inflammation within the heart vessels, infection, heart attack, high blood pressure, clot, and strokes, etc. So the bacteria that is associated with the gum disease, they are gram-negative, person who does not have good oral hygiene, they will have a higher number of gum disease causing bacteria as compared to the person who are healthy.
So periodontitis can have implications on respiratory health. The bacteria in the oral cavity can initiate or progress respiratory infections such as pneumonia. Oral candidiasis is a symptom or can be caused by the inhalation of corticosteroids. And the inhalation of bacteria in the oral cavity can increase the development of pneumonia.
So here's some more oral manifestations with patients that have respiratory disorders. The first and most important is xerostomia, also known as dry mouth. This can be sometimes due to their medications that dry their mouth out or mouth breathing and things like that. You also have halitosis, which is like extremely bad breath. You'll also have dental caries or decay and periodontal disease in these patients, and then you'll see some types of oral cancers, which we'll go over towards the end of the PowerPoint. You definitely want to encourage your patients to brush twice a day. Brush for 2 minutes. Make sure they're using products that are going to increase that salivary flow, and things that include or things that are included in that would be like gums. If they chew gum, you want to get the kind that has xylitol, because that'll induce the salivary flows to produce more saliva, and as well as Biotene mouthwash that does the same thing. And then also drink more water. Just make sure that they're drinking enough to keep that salivary flow and the moisture within the oral cavity.
Okay.
So I'm going to go over some systemic medications with periodontal side effects. And I know y'all are very smart noses, and also feel free to eat if y'all want to. So there is some medications that you need to be out on the lookout for, like phenytoin. It does have an effect of gingival overgrowth. Anti-anxiety agents medications that also increases biofilm formation. And antihypertensive that also increases gingival inflammation. Calcium channel blocker medications also induces gingival overgrowth. And immunosuppressant medications, those also have an effect on the periodontium.
Especially the calcium channel blockers and also the antihypertensive. These are so commonly used medications, so you need to know what side effects they can cause, so you can prevent it. You can give care to your patients according to that. Now I'm going over OHI, what we can do. So everyone, regardless of their condition, they need to brush 2 times a day for 2 minutes. We do recommend electric toothbrush, but I know in nursing home with residents, it becomes harder sometimes to use electric brush. So you need to use, if you're using manual toothbrush, make sure it's really soft, bristles are really soft, and you need to do it in a correct way. For dentures, soak the dentures in a tartar solution and remove stains from the denture brush. We did bring some denture brushes in our goodie bags. Floss daily. Water flosser is a really good substitute with people with dexterity issues who are aged. We also bring different kind of interdental brushes that you can use, because sometimes using a floss thread is really hard with older patients. And regular dental visit and exams if possible. Everyone needs to go to the dentist twice a year, but patients who have progressive gum disease, they need to be in 3 to 4 months appointment, which we call perio-maintenance appointment. And antimicrobial mouth rinses are not recommended for Alzheimer and dementia patients, so we need to be lookout for that.
Okay, so next we're going to go over the brushing instructions for dementia and Alzheimer's patients.
You want me to sit down?
I got it.
Okay. She has to sit down too. So what you're going to do is, with your dominant hand, go over
your patient, have them put their dominant hand on you over. This thinks that they have control over brushing their teeth. And as you're brushing their teeth, you're going to press down on their shoulder and control the toothbrush. This is going to make them think that they're in control and be more compliant with you brushing their teeth.
Okay, so I'm going to go over the removal of dentures. You always want to have or encourage your patients, if they can, to remove the denture themselves because they are more familiar with the piece. If they are unable to, we're going to talk about how to take out the maxillary and mandibular dentures. So for the maxillary, first, you want to stand at the 11 or 12 o'clock position. Just like on a regular clock, 11 to 12 would be right about here, or like right here, or straight behind her. First thing you want to do is take your thumb or your index finger and kind of remove or stick it between the molars or the back teeth and the side of her cheek. So you would stick your thumb or index finger inside, press down on the back side of the denture gently to remove the seal, and then just pull the denture out. You want to do that on both sides. And then for the mandibular, doing the same thing, but you may want to stand at the 9 o'clock position, which is just beside her, or 8 to 9. And then you want to do the same thing, same technique, but you'll just push up on the denture gently to remove the seal or break the seal, and then push it up.
Okay, so just like how Summer mentioned, it's exactly almost the same for a removable partial prostheses. It's best to have the patient remove the partial him or herself because they know their mouth better than anybody else does. If they're unable to remove the partial themselves, just the same way that Summer was saying, 11 o'clock in a vertical motion, because you don't want to pull it to the right or to the left and end up maybe damaging the prostheses or the denture. And make sure you have even pull on both of the sides. No, don't want to pull down on one side more than the other.
Next, I'm going over how we can care of our dentures and prostheses. So, it should be rinsed after eating to remove any food debris. Should rinse thoroughly after cleaning to remove all cleaning agents. Use only warm water to aid cleaner in removing biofilm. Always follow manufacturer's instruction for cleaner. Empty and clean dentures container daily and should be removed from mouth 6 to 8 hours per day. One thing that we see with older patients, sometimes they don't want to take out their dentures every single day, especially nighttime. The best example you can give them, what happens if they keep wearing the same old socks every single day without washing it, without taking it off. One day it's fine, 2 days it's fine. After 3 or 4 days, the socks get stinky. After 3 or 4 or 5 days, it can cause some skin infections, some itching. Same thing goes with our skin and our mouth. So if they're wearing their dentures, they're not taking it off, they will have a higher chances of getting infections in their mouth. And never use any hot water, abrasive cleaner or bleach while cleaning the dentures.
So next we will go over the care of bridges. So bridges and beneath the connectors are prone to biofilm retention. Oral irrigation is best to remove the loose debris that is up underneath there. Direct the toothbrush filaments under the prostheses to clean gingival surface, and the abutment teeth, which are the teeth that hold the device on into the gingiva, are more prone to caries due to the biofilm buildup that is there.
So we're going to play this short little video of oral hygiene aids.
Brushing alone is not enough. Even if you use a high-end electric toothbrush, you still need to floss. WaterPit Complete Care puts you in control by combining water flossing and electric toothbrush technologies, providing all your brushing and flossing needs in one convenient, easy-to-use, and clinically proven device. In recent clinical studies, WaterPit Complete Care was up to 50% more effective for improving gum health versus string floss, and removed up to 99.9% of plaque from treated areas. WaterPit Complete Care is available in several different models and colors. Each features an assortment of flossing tips, 90 seconds of water capacity, 10 water pressure settings, and requires only one outlet. The difference between the models is the toothbrush. Choose Complete Care 5.0 for the triple sonic toothbrush, which features 3 modes: clean, whiten, and massage. Or choose Complete Care 5.5 if you prefer the rotating action of the triple clean oscillating toothbrush, which features 2 speeds and a massage mode. Both toothbrushes feature a 2-minute timer and a pacer that pauses briefly every 30 seconds to signal when to move to the next area of your mouth. They also include multiple brush heads, a premium travel case, and a rechargeable battery, which automatically charges when stored in the convenient inductive charging base. A recharge indicator light lets you... Brushing alone is not enough, even if you use a hot...
Just something I want to add to the water pick. You want to try to do it on the lowest settings first and then gradually go up. So we're going to play a short little video about the care of dentures. I'll explain it after the video.
So, never use really hot water on your denture. Always use warm water. About 1/3 fill the sink, because this will allow any shock to be absorbed if you drop the denture by the water that's in the sink. Then you take the toothbrush, wet the toothbrush, take some soap and add it to the toothbrush. Then take your denture, wet the denture and run some water over the toothbrush and start at the back corner of the denture and then go all around the front of the denture, brushing every tooth surface and surface of the denture base plate. Turn the denture over and brush the inside of the denture using the same toothbrush, just a forwards and backwards motion over every surface so that it's all nice and clean. This will help keep the denture in good condition and prevent any scratches on the surface of your denture. Turn the taps off when your dentures, when your sink's a third full. Rinse with the water. Any further little patches of debris you can see on the dentures, give them another little rub with the soap and water. Make sure you use a cross action as well on those back teeth to get them all nice and clean. Rinse the toothbrush and the denture in the water, rinsing away any water. A final rinse of fresh water, and there we are. The denture's all nice and clean and ready to wear.
So when you clean the dentures, you don't want to use a toothpaste either, because toothpastes are abrasive and they can scratch the dentures, okay? Also, when you clean the dentures, another helpful little tip, you can put like a towel in the sink so you don't break the dentures. You don't want to try to damage the dentures. Dentures are really expensive. And also like do 2 the patient's dentures at a time, and you can also write the name of your patient on the little baggie so you know whose denture it goes to as well.
So next we're gonna go over brushing. And we actually have a model too. I'll send it to you.
A periodontist, that shows you from normal all the way to. So with regular brushing, with a regular toothbrush, you want to aim the bristles at the right back of your hand and keep it on. Jiggle, 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 sweep down, sweep away right up. For the anterior teeth, we're going to do a tilt to slow motion.
What?
You're going to want your fluid to brush it all the way. So applying too much pressure to your toothbrush or a rubber toothbrush can cause recession of your gums. So if you're electric, make sure you're aiming at a 45-degree angle and tilt gingiva. Let it do the work for you. And you do a sweeping motion down, it's called the modified Jackson method.
The ambulation is very important, and this is what we not learn through commercials and sometimes most of the time when we go to dental office, no one teaches us. We need to place our brush 45-degree angle when we're doing the upper arch, and when we're doing the lower arch, same 45-degree angle, and make sure we're sweeping outside. So it is cleaning the contact areas between the teeth.
But also, like, as Emily said, the electric toothbrush, your best friend, because you let the electric toothbrush do all the work for you. You don't have to do really anything. Just hold it there, 1 or 2 teeth, and move on.
So next, we are going over pathology. Pathology is very important because we do want to know what condition a patient have in their mouth and what is the best care we can provide them according to that. So for our oral examination, that's what we are doing in our clinic when a patient comes. Before we proceed with anything, we check their intraoral, extraoral examination. So you need to palpate the lips, the buccal mucosa, which we call cheeks, the hard and soft palate, floor of the mouth. We need to palpate the tongue. We take the tongue in our fingers, of course we're wearing gloves, and then palpate it to see if there any abnormality, if there anything that we should be concerned of, and stop our treatment. And examine the gingiva and the alveolar mucosa, vestibules, dorsal, upper and lower surface of the tongue, lateral borders of the tongue, and also the oropharynx. So Emily is going over and she will explain you how we do it in our clinic and what is the proper way.
We're looking, we pull down, we're looking at her lower lip, we're looking at her buccal mucosa, which is the cheek. You're gonna feel, you're gonna palpate everything. You're gonna feel the hard palate. You're gonna press, ask the patient, does that hurt when I press? 2 fingers down into the floor of the mouth, and you're using your other fingers to press on the bottom of her chin, and you're trying to get your fingers to touch. I can take this tongue out. So you're gonna press, you're gonna pull your patient's tongue out, wrap the tongue in gauze, tell the patient to stick their tongue out. This is when you can get better control, turn it to the side. You want to look at the ventricle, lateral borders of the tongue. Now this is the number 1 place that oral cancer can start. You're gonna lift the tongue up, look, you're gonna let it go side to side, look. And that's it.
Also, another place where oral cancer can hide is, let me see this tongue. Can you put the tongue back real quick? It's on, okay, you feel like where your back teeth is and where the inside of your mouth and then your tongue, right? So if we open, right in here, move this tongue over, and right in that corner is that sweet spot. That's where a lot of the oral cancer hides as well. So you just gotta move the tongue back, tell them to relax, and then push it this way and look in that little sweet honey spot.
Our teacher calls it the peanut hole because if you eat peanuts, it always gets stuck back there, and that's where you always want to look.
Okay, so we're going to go over some denture-induced oral lesions that are pretty common that you'll find within your patients. This one is just caused by irritation. It's going to be an isolated little red to white patch of skin, and basically it's just where the denture has rubbed or irritated the gum tissue underneath the denture. So contributing factors, like I just kind of said, it could be an ill-fitting denture, a rough spot on the denture that's just constantly rubbing on the patient's gum, or it can be something like a little piece of food or anything, any little particle that has gotten underneath the denture, between the denture and the gum tissue, that has just irritated it.
Okay, another denture-induced oral lesion. You'll see this a lot in patients who have like complete dentures, and they never take it out. This is the inflammation, it's denture stomatitis. It's the inflammation and erythema of the mucosa. It's completely covered by the denture, so this is why it's important to inform our patients that they need to take it out at night. It may cause pain and burning. It's also associated with C. albicans. Contributing factors is poor oral hygiene. If you see this in a patient, just get in contact with their dentist and see if they can realign the denture. This can be a problem as well.
So the next one is ankylosing. It is deep fissuring at the corner of the mouth. There are many other things that can cause it, and which are poor oral hygiene, fungal infection, excess saliva, and vitamin B deficiency. So at the beginning, when patients start getting denture, they have more saliva in their mouth, and this could cause it. So we just want to make sure that patients don't have any oral pathology in their mouth because of dentures.
So the next oral lesion is candidiasis. It's the fungal infection most caused by C. albicans. You're going to see white patches with redness. This is a very good picture of that. And contributing factors for this is poor oral hygiene, overwearing their dentures, not taking them out, immunocompromised patients with diabetes, xerostomia, and also patients who inhale corticosteroids and do not rinse their mouth afterwards.
Alright, and the next is the most important one. It is a squamous cell carcinoma. It's going to be a scaly red raised patch, or it could look like a wart in the mouth. It can vary in size. It can be really small, may not even be all that noticeable, or it can be very large like this one is. It is the most common primary malignancy of the oral cavity. It's very serious and something you want to take care of early on, so you definitely want to do the intraoral exams with your patients to make sure that you're checking to find these things ahead of time. It can infiltrate adjacent tissues. It can spread. It can metastasize to the lymph nodes in the neck, and then it can even go to like the lungs or the liver. Patients that would have these would definitely be a patient that has a history of smoking or tobacco use. It could just be a DNA genetic mutation that they have, or it could be any excessive exposure to sunlight.
So the last slide, oral cancer. According to American Cancer Society, the majority of new cases of cancer in the US are adults 55 years or older. The median age of a person with newly diagnosed oral cancer is 62 years old, so that's why we need to pay attention to our senior residents. Most common sites of oral cancer are floor of the mouth, ventrolateral border of the tongue, oropharynx, and buccal mucosa. The survival rate is higher for anterior oral cancer than the posterior one. Just like Emily and Summer mentions, we need to pay attention to the sweet spot where the cancer is with carcinoma is hiding. We need to pay attention. Squamous cell carcinoma is the most common type of oral cancer, and it is the second most common type of skin cancer in humans. Any oral sore, it could be ulceration, irritation, that does not go away within 2 weeks, it needs to be checked. It needs to be for biopsy.
Any questions?
I hope you guys like it.
Thank you. Well, we got goodie bags for y'all too, okay? And feel free to take some breakfast.
Okay,
Please.
wanna go over there? Oh, sorry.